So we'll first start with our learning objectives. We're going to talk about recognizing the signs and symptoms of malignant hyperthermia. We'll discuss the genetics of malignant hyperthermia and identify some of the different presentations that pediatric patients can show us. We'll start with a case presentation. So we have a 9-year-old male who presents to the OR for an open inguinal hernia repair. He's a healthy patient. He's a competitive tennis player. He takes no medications or has any allergies, and this is his first anesthetic. When you talk to family, they report no anesthetic complications in the family. Prior to the case, he received some oral midazolam. He had an inhalation induction with sevoflurane. An IV was established, and he was intubated with an appropriately sized endotracheal tube. And maintenance was continued with intermittent boluses of fentanyl as well as sevoflurane. 90 minutes into the case, the patient was noted to be tachycardic into the 170s. His end-tidal CO2 had climbed into the 70s, 60s and 70s, despite modest increases in his minute ventilation. An axillary temperature probe was in place, and it was reading 38.4. And when you talk to the surgeon, he reported some abdominal musculature tension or tightness. Given those circumstances, everybody was appropriately alarmed, and help was called. So, what are we concerned about? Well, given the signs and symptoms, we were concerned about malignant hyperthermia. So what is that? It's a rare, potentially fatal inherited disorder of skeletal muscle that with triggering agents or when exposed to triggering agents can lead to a hypermetabolic state in which you get increase in end-tidal CO2 production, increase in heat production, and death if it's not appropriately treated. Malignant hyperthermia, was first noted or reported in the 1960s in Australia. Thank you, Dr. Gerla, for your contribution. Shortly thereafter, a swine model was reported, and the first use of dantrolene was used in that pig model in the 1970s, and achieved FDA approval in 1979. I think the turnaround in 20 years is incredible. The fact that we could go from a case series to an animal model to an antidote is just incredible, and kudos to those individuals who were involved in that process. MH susceptibility, patients typically have a mutation within one of 3 genes. That's the RYR1, which is located on chromosome 19, CA-CNA1S, which is on chromosome 1, and STAC3, which is on chromosome 12. There have been case reports or documentation of MH-susceptible individuals with all of those particular gene receptors. And when you expose those receptors or abnormal receptors to a triggering agent, then it can lead to an acute crisis. I apologize, I don't know why there's a missing part there, but an updated list of the most updated list of causative mutations to lend itself to MH susceptibility is on the European Malignant Hyperthermia Group website, which I have a link to in the references. MH is an autosomal dominant disease process, but it has an incomplete penetrance, meaning patients who are MH susceptible can be exposed to triggering agents multiple times before they develop an acute crisis or malignant hyperthermia. Mutations within those genes can occur as high as 1 in 1,500, but because of that incomplete penetrance, actual cases of acute malignant hyperthermia are reported as 1 in 5,000 to up to 1 in 100,000. These mutations are described in every country, every ethnic group. The reaction is more common in men than women, about 2 to 1, and children under the age of 19 account for about 50% of the reactions. A number of disease processes are associated with malignant hyperthermia. I won't read them all specifically, but the first First four are associated with RYR1 mutations. There's some growing body of evidence that exertional rhabdomyolysis may have some implication into developing malignant hyperthermia, but we're not 100% sure at this point, and it may actually be a different receptor, but ongoing research is going on. And then the same is true for severe statin-induced myopathy. Excuse me. So the triggering agents, they're all of our halogenated volatile anesthetics: halothane, isoflurane, sevoflurane, desflurane. The older historical anesthetics also can trigger ether and chloroform, and then the depolarizing muscle relaxants like succinylcholine. Non-triggering anesthetics, nitrous oxide, opioids, benzodiazepines, all IV anesthetics are all safe, as well as the muscle relaxants and local anesthetics. So what happens when a patient who's malignant hyperthermia susceptible gets exposed to a triggering anesthetic? Well, that triggering agent activates a mutated receptor. That receptor turns on, and it releases an unregulated amount of calcium into the sarcoplasmic reticulum of the skeletal muscle. That leads to a sustained muscle activation and contraction, which increases both anaerobic and aerobic metabolism, which leads to an increase in CO2 production, an increase in heat production, and that's what leads to an acute MH crisis. So what are the signs and symptoms? Well, muscle rigidity is a very specific sign. Increased end-tidal CO2 production is a specific sign, as well as rhabdomyolysis. Some other nonspecific signs and symptoms are tachycardia, tachypnea if their patient is spontaneously ventilating, and acidosis, both respiratory and a metabolic acidosis, as well as fever and hyperkalemia because of the rhabdomyolysis. Hypercarbia by far is probably the most consistent presenting manifestation of malignant hyperthermia. And then generalized muscle rigidity in the presence of a non-depolarizing muscle relaxant is pathognomonic for an acute MH crisis. So if you have a patient, you're concerned. Temperature's up, their end-tidal CO2 is up, and you have given a dose of a non-depolarizer and they still feel tense or rigid, the hairs on the back of my neck are standing up, and I'm very concerned about malignant hyperthermia in that situation. Arrhythmias are very common, most commonly sinus tachycardia, but others can be present, like ventricular tachycardia as well as ventricular fibrillation if the hyperkalemia overwhelms the system. Hyperthermia often is a late sign, just because patients, especially in pediatric patients, we expose them, they cool off, and it takes a while for that heat production to have clinical signs. And then myoglobinuria is very common as well. The presence of dark or cola-colored urine indicates a concern for rhabdomyolysis. So when I am concerned about MH, one of the first things that I'm going to do is I'm going to get an arterial blood gas. And what I'm looking for is specifically a combined respiratory and metabolic acidosis. So we know that MH is a hypermetabolic condition where you get an increased end-tidal CO2 production because of the aerobic metabolism, as well as you get to a point where you outstrip the energy source and you go into anaerobic metabolism and you get a metabolic acidosis as well. So what I'm looking for is a combined respiratory and metabolic acidosis. If it's been going on for a while and you have rhabdomyolysis, hyperkalemia is often present, an elevated CK level, as well as myoglobinuria, and rarely, in about 5% of acute or fulminant MH crises, you can get disseminated intravascular coagulation as well as elevated liver enzymes. So what about kids? This was an article that came out in Gomer blog during my fellowship that I always thought was quite funny, despite all of my attendings telling me that they're not little adults. So this was an article in Pediatric Anesthesiology in, I believe, 2014, excuse me. looking at the North American Malignant Hyperthermia Registry. So when patients have MH crises, the providers are asked to fill out a questionnaire about those particular cases. And all of the data is kind of collected, it's reviewed, it's then used for research purposes and publishing, very important guidelines or analyses like this. And what they found was in pediatric patients, the most common initial finding was sinus tachycardia, followed by hypercarbia and then a rapidly increasing temperature, kind of in that particular order. Younger children probably do because of their less muscle mass, typically had less muscle rigidity and lower CK or peak CK levels compared to adult counterparts. But they also had higher peak lactic acid levels compared to adults. Some other conditions that can mimic malignant hyperthermia, light anesthesia, right? Tachycardia, kind of muscle rigidity can often kind of look like an MH type episode, especially on emergence. I feel like as a hotline consultant, one of the common calls I get is, oh, we were waking the patient up and they got really rigid and they were kind of hypoventilating and their end-tidal CO2 went up. Very, challenging to delineate at the time, but often a very common call. Hypoventilation, increased CO2 absorption, say for laparoscopy, and then iatrogenic fever. We, as a pediatric anesthesiologist, we focus a lot of time on trying to keep patients warm, and sometimes we can overdo it and make them hyperthermic. Others would be the hypermetabolic conditions like neuroleptic malignant syndrome, serotonin syndrome, thyrotoxicosis, pheochromocytoma, and sepsis. During the COVID pandemic, one of the very, very common calls were a patient was admitted to the emergency room with respiratory failure, found to have a COVID-19 infection. They received a dose of succinylcholine, and then now their temperature's 41 degrees. Is this MH? And oftentimes it was not, fortunately, MH, but patients, it's not uncommon, at least when you look globally, that patients can mount profound hyperthermic reactions in the settings of an acute illness. So I think it's very prudent to think about MH when you have a high fever and an exposure to a triggering agent, but sometimes it can be due to the infection itself. And then other things would be drugs of abuse. So cocaine, ecstasy, and methamphetamines can also cause hyperthermia. So going back to our patient, so he's got tachycardia, hyperthermia, and increased end-tidal CO2 despite increases in minute ventilation and muscle rigidity. What should we do? Well, we should call for help, because if the ship's sinking, we want some friends. So we want to discontinue the volatile anesthetic, give some other sort of IV anesthetic. We want to flush the machine. Turn your flows up as high as they will go. Get rid of that volatile anesthetic. And if you have, strongly recommend placing charcoal filters to kind of remove all of that residual volatile anesthetic. I want to hyperventilate as fast as the patient will allow me without causing lung injury with 100% FiO2. And then the mainstay of treatment for malignant hyperthermia is dantrolene. Dantrolene, dantrolene, dantrolene. Do not let the other things in the treatment of MH get in the way of providing dantrolene. Obviously, if there's a life-threatening arrhythmia, then that takes precedent, but everything else should be done after the initiation of dantrolene. Actively cool the patient, cold saline, pack the groins, neck, head, whatever with ice. Treat the hyperkalemia to ensure that there's no life-threatening arrhythmias with your usual agents like calcium, dextrose, and insulin. I'd avoid probably the beta-2 agonists in a patient who's already usually extremely tachycardic. And then treat any dysrhythmias with the usual standard medications, with the exception of the calcium channel blockers, as dantrolene is a very weak cardiac calcium channel blocker, and it can kind of unmask arrhythmias. You want to ensure that there's adequate urine output, so definitely fluid load these patients, especially if there's evidence of rhabdomyolysis. And then your usual monitors. It should include core body temperature, heart rate, blood pressure, urine output, and then continue treating with dantrolene until you have at least 24 hours of metabolic stability. The subsequent doses are dantrolene 1 milligram per kilogram every 4 to 6 hours, and there's still some kind of recommendations out there for both intermittent dosing as well as continuous infusion of dantrolene. My personal bias is I don't recommend the continuous infusion anymore. Just with the newer formulations of dantrolene being so concentrated, it's really difficult to provide, especially in pediatric patients, to provide that small amount of dose. So the kind of recommendation that I tell providers is just give an intermittent bolus dosing. The other thing is dantrolene is pretty hyperosmolar and pretty basic. I think the pH on the older formulations is about a pH of 11, so it increases the risk of the risk of extravasation and tissue injury is pretty high. Recrudescence is very common. So recrudescence is the recurrence of hypermetabolic symptoms. So increase in end-tidal CO2 production, increase in core body temperature, an increase in their minute ventilation requirements, muscle rigidity. If those occur after you've gone down the treatment route, don't wait for that 4 to 6 hour mark to redose. If you need dantrolene, give it. In any concern of a patient who had an MH crisis, you've gotten them under somewhat metabolic control, but then they show hypermetabolic symptoms again, give it early. And I know that gives our pharmacy colleagues a little bit of kind of panic. Well, the recommendations are, well, that's true, but we have to take care of the patient first. As I mentioned, 2 formulations of dantrolene, the Dantrium and Revanto. It's a 20 milligram vial that must be reconstituted in 60 mils of sterile water. I don't know if anybody's ever made that solution. It is extraordinarily difficult to get into the solution. And that's why it's very important, if you have an MH crisis and these older formulations, grab friends, because you can have up to 36 bottles, especially in bigger patients, that you can give at one time. And it takes a long, long time to get that stuff into solution. Newer formulation is called Ryanodex. It's 250 milligrams that's reconstituted in 5 mLs of water. Much quicker, within around about 30 seconds to a minute. The current recommendations is having 3 instead of 36 vials on hand, and there's no documented benefit of one formulation over the other. However, we know that delay in treatment with dantrolene is associated with increased morbidity and mortality. I'm not saying that Ryanodex is better, but if I can give a single dose all at once, I would prefer it. At Children's Nebraska, we have the Ryanodex on formulation, or formulary, excuse me. The other thing, going back, the Dantrium and Revanto have a large amount of mannitol in it. So if you've got a pediatric patient and they're putting out a lot of urine, you want to make sure that you keep them adequately fluid resuscitated, because they can get quite intravascularly depleted with the amount of mannitol that's in that formulation. So going back to our case, aggressive cooling measures were undertaken, but his Tmax was 41.3 degrees Celsius. Unfortunately, this case occurred in Peru, and dantrolene was not immediately available at the hospital. It was about an hour away. The reason I got involved in this was a anesthesiologist from Chicago recently went to Peru to visit friends. One of her friends was an anesthesiologist as well. She called the friend from Chicago, hey, I've got a case of MH, what do I do? The friend then called the MH hotline. So kind of a roundabout way to get involved in this, but very scary situation given the fact that this was truly a very severe case of MH and so far away from dantrolene. He was taken to the ICU, intubated, sedated, and paralyzed. His minute ventilation was 4 times his expected amount, given his weight and height. And his first arterial blood gas in the ICU was a pH of 6.9, with a PCO2 of 76, a PO2 of 55, and a bicarb of 8, despite being on 100% FiO2. When the dantrolene finally did arrive, they gave him 2.5 milligrams per kilogram in 3 different doses. I'm not sure if I mentioned at the time, if you have a patient who is in an MH crisis, if you give 2.5 milligrams per kilogram and you don't see improvement in your metabolic symptoms, so your minute ventilation doesn't go down, your end-tidal CO2 doesn't go down, your temperature doesn't go down, your muscle rigidity is not improved, continue giving 2.5 milligrams per kilogram until you see improvement. If you get to about 15 milligrams per kilogram and you are not seeing improvement, I'd start thinking about other processes that could be causing your symptoms that you're seeing. After those 3 doses, his temperature and end-tidal CO2 began to decrease. He continued on 1 milligram per kilogram every 4 hours, and he required a total of 3 days of dantrolene. He was extubated on post-op day 6, and he kind of struggled in the ICU with a prolonged sedation wean and some acute kidney injury. Fortunately, he was discharged on post-op day 14 after a prolonged sedation wean. This graph right here is the MH clinical grading scale. So very historical paper from anesthesiology in 1994, where a group of very intelligent individuals sat around a room and they reviewed all of the cases that were in the North American Malignant Hyperthermia Registry to that point. And based on the different criteria and processes that they saw, they assigned a point value, which they then can use to say this is very likely MH or probably not MH. And the way you grade it is there's different criteria for each process. If you qualify for 2 different criteria within the same process, you just get the higher point value. So going through this particular patient's clinical grading scale, he had generalized rigidity, he had a CK level greater than 15, he had a respiratory acidosis with a PCO2 greater than 60, he had rapidly increasing temperature, he had sinus tachycardia, and at the time we did not know of any family history. So 15, 30, 45, 63, is that right? Yeah, 63. So the way you score it is look at that, and then given the likelihood, so he was 63, so he was almost certainly an MH episode. So it's just a nice tool to kind of, if you've got your kind of feelers out and you're like, I don't know, kind of, it also helps you work through the different processes. So what now? You've got a patient who had an MH crisis that has recovered. How do you counsel them? Well, first, I always document the triggering agents as an allergy within the electronic medical record, and then consider further diagnostic testing for MH susceptibility. I always encourage callers to the MH hotline to report the event to that North American Malignant Hyperthermia Registry. Fortunately, MH is a fairly rare disease, and the more information we can get from it, the better we can help guide providers and patients with better data points. We go back and once you have a big stressful encounter, parents and families often kind of talk to other relatives. It's like, well, yeah, Uncle Johnny had an episode way back when that people don't always think about at the time in that very brief preoperative meeting. And then also, kind of looking at other things, obtain a history on, any abnormal responses to exercise or heat, or, even that response to statins as well. Arrange for postoperative follow-up. Very important. These patients need, longitudinal follow-up. Ensure that they have a good primary care provider, and then also neurology can be a very important specialty to follow as they go on or get older. And then the MHouse website and organization has a bunch of, both support groups, resources, things like that, that can help families kind of navigate a new diagnosis. So after talking with the parents, a maternal uncle died after surgery following a car accident under unusual circumstances, and then a maternal great uncle also passed away after appendicitis under unusual circumstances. But no further events were able to be obtained, so difficult to know. So does this family need testing, and does the patient need testing, do the family members need testing? Well, I would say yes. There's two different modalities for testing. The gold standard would be a muscle biopsy with halothane contracture testing, and then more commonly that is being done now is genetic testing. Cathine halothane contracture testing is the gold standard. There are very few false negatives, only a few false positives. It is probably the best thing that you can do for it. Unfortunately, it's another invasive surgical procedure, and there's only 5 centers in North America that actually do this. The processing of the muscle tissue is very rigorous. The kind of protocol that is required to do it, to get accuracy, is very stringent, and only a few places do it. And then there's also time, weight, and age requirements. Most organizations or these testing centers require you to be at least 12 years of age, be over 40 kilograms, and then you also have to be at least 6 months out from your acute MH crisis. More commonly, what is being done now is targeted gene testing. So typical MH panels test for those 3 genes that I mentioned before. The cost can be anywhere from $500 to $2,500. The good thing is it's minimally invasive. It's just a blood test. It may save an individual from a muscle biopsy, and it can be done locally. The downside is not every single patient who is MH susceptible will have a pathogenic variant. So the bummer always is you have a patient who has a MH crisis, you get testing, and it comes back as an indeterminate variant. I would say you still treat that patient as MH susceptible, and then as we get more and more patients who have a similar variant, say we get 15, we get 25 individuals who have that same variant, over time, maybe we can say that that truly is a pathogenic variant. And that European malignant hyperthermia group, they add, probably every 6 months, they add pathogenic variants to that list. So the patient had testing. He was found to have a pathogenic variant in RYR1. His mom, his sister, and his dad also underwent testing. His dad was a normal genotype, but his mom and sister both had the same pathogenic variant. Unfortunately, he struggled with muscle cramps for over a year, and unfortunately had to give up competitive tennis and had pretty significant heat intolerance after it. So what if anybody needs anesthesia in the future? Well, you're going to treat them as MH susceptible. I'm sure all of your organizations have kind of a protocol, but what I tell patients or tell providers, disable your vaporizers, whether that's take it off or just tape over it, that's dependent on your organization. Flush the machine according to the manufacturer's recommendations. Apply filters and then a non-triggering anesthetic. And then make sure you have appropriate monitoring, and I don't think you need dantrolene in the room, but just make sure you know where it's at. Going back to our patient, they all had safe non-triggering anesthetics subsequently. The parents have been very active in MHouse, and they are actively trying to bring dantrolene to Peru and become a standard of care. And this is Derek. He was the patient that had this episode, and older picture, I think he's probably 16 now. So yeah, very interesting. And unfortunately, my reference page did not show up. So I think we're going to do questions afterwards. Okay. Thank you, everybody. Appreciate your time and look forward to questions.
Thank you, Dr. Hamlin, for that talk. We are now going to be welcomed by Dr. Jessica Geller. Dr. Jessica Geller is an associate professor in anesthesiology at the University of Nebraska Medical Center. She's clinical service chief of pediatric anesthesiology, section chief of pediatric comprehensive pain medicine, and director of perioperative services at Children's Nebraska in Omaha. She currently serves as chair of the Children's Specialty Physicians Board of Directors at Children's Nebraska as well. She has served on the Board of Governors for the Aoca since 2020 and has been on the chair of Professional Education Committee for the same since 2021. She graduated from Lake Erie College of Osteopathic Medicine in Bradenton, Florida, completed her residency in anesthesiology at Heritage Osteopathic College of Medicine in Columbus, Ohio, and pediatric anesthesiology fellowship at Nationwide Children's in Columbus, Ohio. In her spare time, she completed her MBA this year at the University of Nebraska. She is also a proud U.S. Army veteran. Today, she will be speaking on opioid epidemic updates. Please join me in welcoming Dr. Jessica Geller.
Thank you so much, Dr. Swally, and thank you everyone for choosing this lecture over the concurrent session in obstetric anesthesia upstairs, but hello to all the on-demand viewers as well, so we'll be able to partake of that too. So about 5 years ago, it always tends to be late on a Friday afternoon. When I at that time was director of the acute pain service, which has been taken over and led by Dr. Swally in the last years, I got a desperate call from a pediatric neurosurgeon who said, "Jess, I need you to help me. I have a kid who I did a procedure on a few weeks ago and he looks rough. I think he's going into opioid withdrawal." This boy, 17 years old, had a subacromial decompression for Chiari malformation, and he had a typical course post-operatively with a protocol that had multimodal analgesia involved. He had an allergic reaction to diazepam, which we actually use pretty typically for the muscle spasms that they tend to have on the back of their neck, and needed an alternative. But when he presented to the emergency room, it had been 3 weeks. He'd lost 20 pounds. When I had met him, I think I actually helped with the pain management a few weeks prior. He was a muscular 17-year-old, just started college, taking 15 credit hours, and had all the good things happening. He just needed to have this taken care of so that he would be able to recover in time for the next semester. So subsequent to that, when he arrived and was in this very poor condition, the story that unfolded comes from, in my estimation and expert opinion, inadequate education for what to do once they were discharged from the hospital after recovery, and then lack of understanding of appropriate management when he was a few hours away. So subsequent to that, when I was having a discussion with this family, it ended up coming out that he went home with, I think, 30 different pills for oxycodone that he had tolerated in the hospital. His mum was a banker and she took meticulous notes and felt like she needed to make sure she documented, kept giving them around the clock so that she could prevent pain. The dose he went home on was 10 milligrams. Once those ran out, they went to the primary care provider who provided them some more in the local area. And then once those ran out, he started to go into acute withdrawal. He no longer had any pain that he was treating, but it had now been over 10 days of taking 10 milligrams of oxycodone around the clock. What he then did is started to go into that acute withdrawal where he had piloerection, nausea, vomiting, extreme weakness. He couldn't keep anything down, so he was then subsequently admitted to the hospital. In the hospital, they put him on a dilaudid PCA, and they hydrated him and then sent him home with dilaudid tablets so that he could continue on in his recovery. He had a bottle that had maybe some remnants of oxycodone from his parents that were 5 milligram tablets, so that when he went home on 4 milligrams of dilaudid every 4 hours, when those ran out, he now was going to 5 milligrams of oxycodone because when he stopped, he felt so bad. So he couldn't keep anything down. He was constipated, and he literally lost 20 pounds during this course. So when he came and arrived to his post-operative assessment in the clinic, he was being carried in essentially by his parent, and was so weak and was so ill they sent him to the ER, and that's when I received the call. I went and talked to this amazing kid and had a critical conversation with him. And his mum, who felt incredibly guilty when I explained to her that the intent was to taper off pretty rapidly after he got home, and it really should have been 1 or 2 doses. And she was just trying to stay ahead and keeping records, and she's a banker and she knows numbers, and she was feeling incredibly guilty. And I told her not to worry about that, but that we were needing to put him on a methadone wean at that point, which of course triggered her to worry that that's how we take care of people who are drug addicts. And I assured her that is not the case in this scenario, but I had an important conversation with this boy and said, you have your whole life ahead of you, and what we do now may change the trajectory of your life. And so we need to take this very seriously, because we need you completely off of this so that you can go back to the course that you have planned ahead for you. He's a straight A student. He's going into engineering, like amazing kid. So over the course of the next 2 weeks, we were able to successfully do a methadone wean, and he left not needing to take any opiates when he went home. And I basically told him to steer clear of them unless he needed something acutely, but that I gave him my cell phone number and his mum and said, I'm going to be watching out for you, but you call me if you need anything. He successfully, I love having good, happy endings to stories, but he successfully was able to completely come off and no longer have those withdrawal symptoms, because he was not taking them to have a euphoric response. He was taking them because when he stopped, he felt so bad. I lead in with this story because it's important to know that as anesthesiologists and as physicians, some of the most important impacts that we can have are surrounding our influence on minimizing opioid exposure at discharge. I'm not part of the proponent of opioid-free anesthesia. I think there are areas of medicine where we've discovered that they aren't needed. Urology is a great example. Sometimes bladder spasms really need other medications, and opioids aren't really helping you. But as they get to the point of discharge, really good education and decreasing the amount that they would even go home on mitigates non-medical use of opiates, overuse. I mean, we had, I think it was Society of Pediatric Anesthesia a few years back, one of the opioid stewardship presentations, they described a parent who was confused when they asked her why they took so much medication. They sent her home with a bottle of oxycodone for her child, and she finished it, but she said, but I've always been told to finish every bottle of antibiotics. So she was conditioned to know that that's how she was supposed to meticulously follow doctor's orders. So it wasn't her fault, but we have to take these types of things into consideration. If you go home with 3 to 5 doses, the likelihood of this type of a scenario occurring is basically zero. So I don't have any disclosures. I'm going to go over some history, the epidemic in the United States, prescribing practices, and non-medical use. The first slide I'd love to show you is, this is one of my favorite ones to talk about. 1996 is when OxyContin was approved by the FDA via Purdue Pharma in 11 months and 14 days. They were very proud of it. It was subsequent to that there was a flood of opioids because they touted from a letter to the editor in 1980 in the New England Journal of Medicine that only had 15 patients on it, that there was less than a 1% chance of becoming addicted if you actually had pain when you started taking opioids. And that's where this got approved, because then it's only every 12 hours. And so it got onto the $4 Walmart 90-day pharmacy formulary. And so then in places where people were having chronic pain, which was not an indication for the long-acting oral morphine that was preceded it, then it became the indication for, well, they have pain and it's not going to be addictive, so let's do this. And they were able to get it very, very cheaply. And those concentrations were 10 milligrams, 20, 40, 80, and 160 milligrams in each pill. And prior to that, there wasn't this level of exposure of opioids to anyone in the public, because as you know, oxycodone is 5, 7.5, and 10. There wasn't anything greater than that. So once they started noting that there was an increase in addiction, non-medical use, and deaths, the first wave transitioned into a second wave when there was 95% purity heroin that crossed the border into the United States. There was less accessibility to these oxycodone tablets, and this heroin availability was extremely cheap, and so they supplanted their addiction and dependence with heroin. The third wave is when we started to see fentanyl mixed in with all of the different counterfeit tablets and the different every kind of drug. It wasn't just opioids. And that's when you saw the uptick of fatalities. And nobody's more familiar than us with the potency and respiratory depression associated with fentanyl, and just the small fraction that it takes for that to come into effect. I've read voraciously on this. I'm going to recommend these three at this time. One was Dreamland, which described this second wave and really the conditions surrounding that. I found it incredibly interesting. Recently on Hulu, they had Dope Sick, and I believe it's Netflix that has Painkiller. And the Painkiller one talks about Purdue Pharma and how they came about getting this particular formulation and the really malicious advertising practices. And the Dope Sick specifically was talking about how it was misrepresented to physicians, and then eventually the physicians were vilified when really in the first intent they were just trying to treat these chronic pain patients they hadn't had a tool for prior. Now, looking at this same trajectory, when you're looking at age-related increases, you still see that between 1999, remember it was approved in 96, and really it was the third opioid epidemic in the history of the United States, but we'll focus on that. There was a greater increase in males versus females that were having overdose deaths involving an opioid. Not all deaths are purely one substance that is used. A lot of times they're all layered together, but if they involved an opioid, they were factored in here. The numbers from 2022 and 2023 are exceeding 100,000 deaths per year. The pandemic had a focus on our health, but it masked the increasing problems that we were still facing in the opioid epidemic. But the synthetic fentanyl and other derivative concomitants are continuing to contribute. They come on the black market. People can get a brick of fentanyl for $10,000 from China and other places, and then when you reconstitute remifentanil, how much is in that vial? It's the same thing with fentanyl. Personally, I always thought to myself, why would I put fentanyl in it? Yes, the high may be higher, but then you're killing off all your customers if you're really thinking on one side of it. Not that they're smart enough to think about that. But with the number of overdose deaths continuing to increase by nearly 30% year over year, it has quintupled since 1999, and nearly 75% of all the deaths involving a drug involve an opioid. Now, when we're looking at all the different ages that are affected, you can see that the highest trajectory you see here of which substance are the synthetic opioids other than methadone. When we're looking at the national overdose deaths among all ages, you can also see that prescription opioids that you see there in yellow, that are used in combination with synthetics. You still see an uptick, but a little bit of a downslide. Then prescription opioids without any others. You can see that there have been some gains made on prescription opioids being the sole reason that somebody has an overdose death, but there is still a lot of room for improvement. When we look at the different age and total related deaths, you still see on this right-handed one, in green you see female and in blue you see male. Who ends up dying from an overdose death ends up being between 45 and 52 years of age and being a white male. And the reason being is they're ashamed of their habit and they're at home and they're alone and there's no one there to rescue them. Naloxone nasal administration is readily available, doesn't need a prescription. Anybody can go to the pharmacy and ask for one to have, just like having other emergency things, and it is able to be used very fast for those that need it. When we look at the data from the National Vital Statistics System, I'm seeing this go ahead faster than it's going there. We see the characteristics of fatal poisonings among infants and young children in the United States. And what you see here, that's much better. Okay, so the far left is opioid-related fatal poisonings for infants and young children. How are infants and young children having these opioid-related fatal poisonings? They access non-secured medications or even medication-assisted therapies at home, and then they accidentally ingest an overdose. When we look at national trends in pediatric deaths from fentanyl, just over the last couple of years, you can see the breakdown in the age categories. While it still leans that it's the 15 to 19-year-olds that get a higher amount of access, there is still representation between fentanyl and non-fentanyl pediatric opioid poisonings, even under the age of 1. I don't know many kids under the age of 1 that can open a pill bottle and take one, but there's still a lot to do here. So when we go back into the history, you can see that the prescriptions increased and then they have been in decline, but they still aren't less than prior to OxyContin coming onto the market. Here is the dispensing rate per 100 persons, and this is on the CDC reporting website. Non-medical use of prescription opioids is experimentation and abuse, and in kids they think that prescriptions are safer because they came from a prescription. So 11 to 13-year-olds are the ones that are experimenting most, and I have a 13-year-old boy, and he's heard ad nauseum why you wouldn't do drugs, but having that misconception that it is safer is why that tends to be something they get exposed to more. Overprescription means I like to do this poll. If you had an opioid prescription at any point in time, how many of you still probably have at least one pill somewhere deep in the darkness of your pill cabinet? Because what if in a dark and stormy night you twisted your ankle and you didn't want to go to urgent care? It still has a little bit of potency. This tends to be the trend when they do studies across the board. So a mismatch between the dispensed amount and used prescription opioids is a significant problem. They've done multiple studies that have updated, and I'll put it in the key points later, but that right-sized dosing of what to send somebody home on has had the biggest impact. Even when I was in residency long ago, I was writing 45 tablets for a lap chole to go home. What they did in Michigan is they found when they called people, asked them if they filled it, how many doses did they take, it averaged 6 doses. That means 39 tablets were there sitting in the back of the cabinet for somebody else to potentially access and use. So now they, in surgery, have reduced it to 15 pills or maybe 10 that they send people home on. So that's a significant drop in how much is being sent home and the education being provided. So as we look at the different surgeries, you have lap chole at the top, lap appy, etc. The median pills consumed is in the lighter color, but the median pills prescribed is in the darker. What is the number one reason that they gave for just flat giving the same amount? They didn't want to get a call in the middle of the night, that they ran out of pills, the surgeons didn't want it, and so they prescribed enough to mitigate that. What they found as they decreased and right-size dosed, people were still not calling for refills. So they had been over-prescribing all this time to prevent this effort. Exposure to opioid analgesics where non-opioid analgesics are appropriate. An excellent study came out on third molar extraction. They were able to follow patients who had never been exposed to an opioid, and they looked at teens, and they found that if they received 15 or greater doses, that in 1 year there was a 20% chance they would still be using opioids for non-medical uses, and in 3 years there was a 10% chance because they received that many doses, and it went up from there. Some would go home with 30 or 45 tablets after a wisdom tooth extraction. In that arena, they have gone to using NSAIDs and Tylenol, and only in extreme situations should anybody be getting opioids. That doesn't mean it's not happening, but I think it's significant to know that that person's life could have changed just because they got their wisdom teeth out and got exposed to an opioid. When you look at the sources of people using them for non-medical use, the grey is given by a friend or relative for free, out of the back of their cabinet, where they keep having them. We did a 50-state study. It's going to get published probably later this year, where we look to see what legislative efforts have been put into place across the states and how they differ from state to state. As you know, we are governed by state legislation, and there isn't, other than the new DEA requirements for those that prescribe opioids that need to have opioid education across the board, but each state governs their own education. On the left side, you see states requiring opioid or narcotic-specific CME. Grey means they didn't have any specific. On the right, you see those that require giving education to patients if they receive them. In the left, you see limits on the number of doses and duration, and on the right, you see e-scribing being mandatory and implemented or in the near future. There's still a lot of grey across that map. This is the states requiring a separate controlled substance permit in addition to the DEA. I'm going to point out Connecticut because one of our esteemed urological surgeons said one of the reasons that he became aware that he was prescribing opioids when he didn't need to is he got tired of jumping through so many hoops to be able to prescribe them that he eventually got to the point he just stopped and he never got any calls. And he realized I probably never had to prescribe them in the first place. Now, when we look at monitoring, many states have prescription drug monitoring programs. Some mandatorily require them to be looked at and annotate in the chart that occurred prior to giving somebody a prescription, but there are many states that do not require that. Now, when we look at opioid stewardship, we say, what can we do in our institutions to have a proactive, preventative policies in place to be able to not only be compliant with state, local, joint commission requirements and legislation for credentialing, but also because we care so deeply about our patients that we don't only think about them when they're in our arena, but we want to make sure that they can not have a bad course that can change their lives, as the potential for the story I told in the beginning. So the electronic medical record now has a prescription drug monitoring program integration where in a lot of places they have it so that within that patient's chart it already has a tab, you just click on it. So having to jump through hoops and go to different websites is already integrated. E-scribing decreases the possibility of a paper script being misused. Having a dashboard where people can visibly see how they compare to others in their discharge prescriptions for morphine mill equivalents or total number of prescriptions is another avenue. There are different pain apps. I'll show those to you in a moment. There's information sheets and calculators. There's hard stops for how much they're prescribing dose dependently, but also how much to dispense. I have several papers coming out this year because we discovered in our own institution back in 2015 there wasn't a lot of limits in the software for how much they sent home, and we found that some people, even on liquids, were being prescribed 3 litres of oxycodone to go home. We have decreased 3,700 prescriptions down to less than 1,200 while we've increased the amount of patients that we serve. And the amount of dispense amounts are nowhere near that anymore. Sometimes I'm questioning whether they gave enough. So a lot can be done with opioid stewardship within an institution. But because we had to be compliant with Joint Commission requirements as well as we had state legislative efforts, we had to go in there and put some of these BPAs and preventative measures in there. And then whenever anyone goes home with a prescription, it automatically, with the after-visit summary printout, has an opioid safety sheet that they have to sign that they received. It gets uploaded, and that is one of the teaching sheets they get over for storage, disposal, alternatives, risk benefits, and where you can turn in excess medications. The patient caregiver education. 90% of expectations come by setting the right expectations for tolerable pain and not zero pain. And yes, you need this medication, but I expect 1 or 2 doses and then be off of it so that you don't have any of those negative effects. This is our post-procedural analgesia prescribing for discharge sheet. It shows minor, mild, moderate, and severe procedures, and it recommends to the surgeons how much they should prescribe, and it does not exceed 20 doses. Here's some more successes we've had, and this is urology again. On the right side, you see how many cases they did in the grey and how many opioid prescriptions went home with them comparatively. When we instituted opioid stewardship in 2018, we saw not only surgeons that were absolutely on board with it, but near elimination from 50% down to less than 10% that even received one. And as we continue on, we see that there is a trend down from opioid prescribing. The prescription drug monitoring program, there's more to learn state by state, but every time a prescription is prescribed, it goes into the database. We even have pet opioid prescriptions go into the database by veterinarians, nearby states putting it in so that we have a more comprehensive picture. And here are some of my favorite apps and tools that you can use in order to have access on hand for the opioid dose converter is one of my favorites. They've had this much in this period of time. I want to turn it into this. It does the cross tolerance calculation for you and does age and weight-based dosing. There's opioid guidelines, there's tapering. The Opioid Rescue is open to the public. Anybody can download this app and say, oh no, I've come across somebody or I have a loved one who has this problem. What do I do next? So that is my whole, we'll answer questions afterwards, but thank you so much.
All right, thank you very much, Dr. Geller. So next up, we are welcomed by Dr. Elena Lin, who will be speaking on point-of-care ultrasound and anesthesia. Dr. Lin is an attending pediatric anesthesiologist at the Children's Hospital of Philadelphia and assistant professor at the University of Pennsylvania Perelman School of Medicine. She is director of the perioperative ultrasound department and leads educational workshops and clinical protocols for bedside ultrasound. Following a research fellowship at the NIH, she completed an anesthesiology residency at Johns Hopkins and pediatric anesthesiology fellowship at Children's Hospital of Philadelphia, serving her pediatric surgical population. Please join me in welcoming Dr. Elena Lin.
Good morning, everybody. Thank you so much for inviting me to speak today. Here we go. All right, so I have no disclosures other than to say that if you showed up for a talk about that 50 Shades of Grey, you're going to be sorely disappointed. Work at a pediatric hospital, keeping this PG-13, so we're talking about the other 50 Shades of Grey, all right? All right. So over the next half hour or so, we're going to discuss the role of point-of-care ultrasound for children in the perioperative period. I work at a pediatric hospital, pretty much solely take care of kids under 18, but all these techniques are also applicable in the adult population if that's your main population. We're going to illustrate lung, cardiac, and gastric applications, and then highlight some of the educational, credentialing, and administrative aspects of integrating a point-of-care ultrasound program into your clinical program. So let's talk about a little bit about why we want to use POCUS, right? So POCUS is a focused, goal-directed question. This is not when you get the echosonographer in the operating room to do like a 30-minute echo. This is, I have a specific question, in 5 minutes or less, I'm going to obtain an answer to that question. It's a rapid test. You do it right at the bedside, so you bring the machine to the patient, and it's completely non-invasive. So certainly ultrasound technology has advanced quite a bit in the last 50 to 70 years. Back in the 1950s is when ultrasound first started really being used. And you can see in that first picture, if I wanted to obtain an ultrasound, I actually had to dump the patient into a giant tub of water. Can you imagine if I said, hey, Dr. Adzik, Chief of Surgery, I need an ultrasound. I'm going to put your patient in a giant tub of water. Like, I don't know about your hospital, but that would not go over well. So luckily, fast forward to the 1990s, and they have these bedside machines, but they're still pretty big, probably bigger than this podium. And, the patient usually would have to go to the machine. Fast forward to the last decade, and our point-of-care ultrasound machines that most departments use, whether it's anesthesia, ED, PICU, are fairly small, about the size of a laptop. We have them on a cart so that they roll easily and they don't walk away, but they're small devices. And most recently, in the last 5 or 10 years, the handheld devices have become extremely popular. So I'm sure there are a couple people in this room with a Butterfly or a vScan Air. These are devices that fit, into your pocket or your purse, and certainly are easy to transport. And as a department, we own a couple so that we can take them for medical mission trips, we can use them for educational workshops, and some of them at this point are completely wireless. So you have a tablet or an iPhone and then a handheld device, and it's completely wireless. So I think as the technology advances, we might get to the point where everybody has an ultrasound, just like everybody has a stethoscope. So when I finished fellowship and was really starting to get interested in this, a very interesting paper came out in anesthesiology, and it was titled Auscultation versus Point-of-Care Ultrasound to Determine Endotracheal versus Bronchial Intubation. So this was a study done in adult patients at UC Irvine. They had the adult anesthesiologist blind, so the patient was intubated, and then the adult anesthesiologist was blinded to whether it was a right main stem, a left main stem, or an endotracheal intubation. So they found in this study that auscultation was only about 66% sensitive and 59% specific. Whereas if you use ultrasound, it was about 93% sensitive and 96% specific. And I would argue in the pediatric populations, it probably makes an even bigger of a difference because our patients are small. You get transmitted breath sounds very easily to the other side. A lot of kids have hypoplastic lungs for multiple reasons, and so you're not going to necessarily hear good breath sounds. And so the accompanying editorial to that article made an interesting statement. Perhaps a stethoscope is closer to a costume piece than ever before. Do you believe what you see or what you hear? So again, I think in the next decade, in the next 2 decades, ultrasound is really going to take over a lot of our diagnostic techniques. Of course, with any sort of technique, there are limitations and risks. So ultrasound is more difficult to do well in obese patients. You just have more tissue that the sound waves need to go through. And of course, ultrasound must be interpreted in the clinical context. The main risk with ultrasound is not in actually doing the scan, right? These are sound waves, they're not gonna hurt anybody, but there is the risk of misinterpreting the data derived from the exam. So if you do a lung exam and you say, oh, the patient has a pneumothorax, and you put a chest tube in, but the patient really didn't have a pneumothorax, you potentially are causing harm to that patient. There's also the theoretical risk of transfer of pathogens if I use the probe on patient A and then use the probe on patient B. That being said, if you clean off the device with the wipes that pretty much kill everything in the hospital, it's no more of a risk than, say, putting the patient on a stretcher and then having another patient on that stretcher, the next day. There is the theoretical risk of thermal injury with the ultrasound probe. Usually we consider this only a risk in high-risk tissues, such as the eyes and in the fetus. That being said, I come from a center where we do a lot of fetal surgery. routinely. These moms have ultrasounds that take an hour and a half because they're trying to get such detail on, unfortunately, kids that have congenital anomalies. And we've never seen any sort of thermal injury in those situations. So I think, again, the main risk is really misinterpretation of what you see on your ultrasound. There are thousands of publications demonstrating the utility of ultrasound. I'm not going to go through them, but suffice this to say, in the pediatric anesthesia realm, adult anesthesia, ED, PICU, adult ICU, there are thousands of publications demonstrating utility. And it's been shown that POCUS education in trainees, so residents and even medical students, is extremely effective. It's being taught earlier and earlier at the University of Pennsylvania, which is my sort of mother medical school. Even medical students are learning POCUS year one. So they do it as an organ system. So if they're doing cardiac, they learn to scan the heart. When they're doing their lung system, they learn to scan the lung. And so they're coming out of medical school extremely fast with this technology. I know the ABA boards on that part 3 where they're doing the Aoca Gs, so the pretend patients, they not only have to be able to interpret the images, but they now have to be able to perform cardiac, lung, and gastric ultrasound as of this year, this coming year, 2024. They're adding the gastric ultrasound. So if you have trainees who are going to sit for those boards, this is something they may be asking you to help them with. All right, so POCUS in the perioperative period can be used for pretty much anything from head to toe. You can use it to look, you can do optic ultrasound, which is good for looking at ICP. You can look at with airway ultrasound for both front of neck access as well as endotracheal tube localization. You can do cardiovascular ultrasound that helps you look at primarily ventricular function, volume status, and presence or absence of tamponade or effusions. You can use it to look at the lungs, to look for pneumothorax, pleural effusion, and airspace disease. You can look at the abdomen to look for gastric volume to assess for aspiration risk. You can look for free fluid in the abdomen and for bladder volume. And then as a procedural indication, you can use for vascular access, whether that's peripheral access, central access, arterial lines. Today, over the next couple minutes, we're going to talk mostly about diagnostic indications for POCUS. But as a side note, since we've been using POCUS for peripheral IV insertion over the last decade or so, our central line rate of placement has dropped dramatically, and I see nods across the board at other pediatric institutions. All right, so I'm going to start with a case. So my first case is an 11-year-old with a history of cystic fibrosis who presented for laparoscopic hernia repair. Towards the end of the repair, the patient's noted to have decreased SATs, requiring higher ventilator pressures, not resolving even after the trocars are removed. All right, so I'm going to go through lung ultrasound 101. In the next 10 minutes, everybody's going to know how to do lung ultrasound. All right, so let me go through this diagram. I was told I have a mouse. Okay, so as you go from anterior to posterior, you obviously run into skin and soft tissues and muscles. And then here, kind of focus your eyes on what you see here, because this is what we want to look at. So bone on ultrasound is going to be dark, and ultrasound beams don't go through bone. So anything posterior to the bone is going to be dark. You're going to have acoustic shadowing. The next thing you want to look for is this bright, shiny line here. Is that showing up? Kind of. All right. So there we're looking at the pleura. So this hyperechoic or very shiny, bright line, that's the pleural interspace between where the visceral and the parietal pleura exist. And then posterior to that, you see lung parenchyma, okay? So as people are starting out, I always tell them to look for the bat sign. And so what we're looking at here is the ribs, which are the wings of the bat. So those are the bones. Again, posterior acoustic shadowing, so no ultrasound beams are penetrating posterior to that. And then the pleural line, which is this shiny white line, and lung parenchyma distal to that. So if you want to use your imagination, it kind of looks like the ribs are the wings of the bat, and the pleura is the body of the bat. All right, so what we're looking for as you're looking at the lung is lung slide. And as you can see here from the video, the pleural line is moving horizontally back and forth as the patient breathes in and out. So if you see lung slide, that means at the area that you're looking at, that we're scanning right here between this rib space, there is no pneumothorax at that rib space. I'd also like to point out this kind of straw-like structure horizontally that's on screen left. That's the diaphragm, okay? So you're scanning down at the base of the lung in the diaphragm. The complete lung exam on any side, you're going to start from clavicle with the probe oriented vertically, and then kind of scan down from clavicle all the way down to diaphragm, okay? So if you see lung slide at that region, there's no pneumothorax, you can roll that out. Of course, you'd have to scan the entire lung to make sure that you don't have a pneumothorax high up, for example. But the absence of lung slide is a little bit less useful. It just means that the lung isn't moving at that region for whatever reason. It could be because the patient has a pneumothorax, or it could be because the patient has a bronchial occlusion, like a mucus plug. It could be because the patient has severe pneumonia or ARDS or severe pleural adhesions. It could be because you're purposely, or maybe unpurposefully, main stem intubating the patient, and all you have to do is pull the tube back a little bit. I actually use lung ultrasound if we're deliberately doing a one lung ventilation in kids, because I like to minimize the amount of radiation in children. So as I'm trying to either left side or right side main stem, I'll look on the opposite lung and see at one point I lose lung slide. And studies have actually shown that lung ultrasound is better at picking up small pneumothoraces as compared to X-ray. So it's more sensitive. All right, so in that last video, it was pretty obvious that the patient had lung slide. You could see that shiny pleural line moving horizontally as the patient was breathing in and out. But sometimes it's not quite as obvious. For example, if the patient is taking very small breaths, you might kind of look and be like, is the lung slide, is there lung slide or not lung slide? It's not quite clear. At this point, we can go to something called M mode, which stands for motion mode. And you'll just hit a button on the machine that says M. And what that does is it plots motion over time. So motion's going to be on the y-axis in this case, and time is going to be on the x-axis, and it plots motion along that line that you're measuring. And so if you look at the screen right for you guys, seizure sign is on the right, and in a normal lung, in a normal ultrasound, if you don't have any movement, you just get kind of these lines that go horizontally, what we call, almost looks like a barcode. When you have motion in an ultrasound, and you know this by kind of just shaking the ultrasound probe away, it becomes kind of hazy, it becomes kind of fuzzy. So in a normal lung that's moving, your chest wall doesn't move very much, or just a tiny bit, and then your lung is going to be moving. So in the top of your screen, you're going to have no motion, or these horizontal lines, and in the lung parenchyma, you're going to have this haziness. So some people call that seashore sign, where if you imagine the horizontal lines are the waves in the ocean, and the haziness is the sand on the beach. If you have a pneumothorax, you have neither movement in the chest wall nor in the lung, and so you're just going to have those horizontal lines, and some people call that the barcode or the stratosphere sign. So lung point is the point at which you see the partial collapse of the lung inside the chest wall. So you have intermittent lung slide at that point. So in this video, you can see, there we go, no lung slide there. It's going to kind of no lung slide there. And we start the video again, but you see lung slide here, and then a point at which there's no lung slide. Let me just go back if I can. So lung slide, no lung slide. And that point at which you have the apposition of lung slide and no lung slide, that's called lung point. Literally, you're seeing the point at which the pneumothorax starts. And so if you can see that, you rule in a pneumothorax. Oops, wrong slide. Okay. I do have to mention a couple artifacts, which are normal. So these horizontal lines that you see here that are equidistant from the chest wall to the pleural line, so that distance is the same as that distance, is the same as that distance. Those are called A lines, and those are normal artifacts that you see in lung ultrasound. These are reverberation artifacts, horizontal lines, and you know that they're A lines because they're equidistant. They march out at the same length. These are normal things. Don't worry about them. Everybody should have these. These vertical lines that go all the way from the pleura all the way down through the parenchyma, those are called B lines. Some people call those comet tails because they look a little bit like that. These are indicative of fluid in the lungs. So the more vertical lines, the more B lines you have, the more fluid you have in the lungs. In the adult literature, they state that if you have 3 or more B lines per rib space, that's indicative of pulmonary edema, and like 10 B lines is worse pulmonary edema than 5 B lines. The pediatric literature is not quite as clear, but certainly the more B lines indicates more interstitial fluid. If you see B lines, though, again, going all the way from pleural line all the way through the lung parenchyma, because your sound wave travels through all that, you know you don't have a pneumothorax, because the air, if it was a pneumothorax, you wouldn't have a B line. Similarly, sometimes you get this very quick shimmering movement of the pleural line, and that's referred to as lung pulse. And what that is just the lung moving in concert with the heartbeat. So especially in small kids, right, their heartbeat can really transmit to the lungs, and you see this very, very quick shimmering. And the way that we know this is lung pulse and not lung slide is because hopefully the patient is not breathing like 120 times a minute. So again, if it's in consort with the pulsation of your heart, that's lung pulse. You can often see this in atelectasis, so the patient's not really breathing well, but you do see the transmitted movement of the heart, and this as well rules out a pneumothorax, because you wouldn't see that quick shimmering of the pleural line if you had a pneumothorax. So in summary, if you see lung slide, if you see B lines, which are those vertical lines, or you see lung pulse, you can rule out a pneumothorax. So there is no pneumothorax at the region that you're scanning. If you see lung point, again, that's that A position where you saw lung slide and then no lung slide, that rules in a pneumothorax. So very quick exam, you can easily do this in about a minute. You can rule out pneumothorax fairly easily. Okay, so going back to that first patient, 11-year-old cystic fibrosis after a hernia repair. So what do we see here? All right, I'm gonna play the video again, there we go. So lung slide, no lung slide. So what's that called? We can just kind of lung point, great. So in that situation, we've ruled in a pneumothorax. In this case, the child probably blew a CF bleb with the positive pressure ventilation during surgery. And in this case, the surgeon then put in a chest tube and the patient did fine overall. Okay. So our second case is a 4-year-old who presented for a liver biopsy. During the process of emergence, was noted to be hypoxic. So what are some other things that we can look for in the lung? We can look for pleural effusion. So effusion or fluid under ultrasound is going to appear dark or hypoechoic, just like a vessel would look. So when you do like a IJ central line, right, the blood looks dark because it's a fluid. In a pleural effusion, you'd see a space between the visceral and the parietal pleura. They'll be separated, filled with fluid. Depending on what the fluid was consisted of, you may see things like floating in it, right? If the blood had congealed, you might see some stuff floating in there. Sometimes if the effusion is so big, you'll actually see like parts of the lung flapping around in it, and people call that floating lung or squid sign. And so there's different looks, but this here is an example of a simple pleural effusion where you just see hypoechoic fluid separating the viscera and the parietal pleura. Ultrasound can also be used to look at lung consolidation. So during that process, the lung starts to look more hyperechoic or more white. You get these white speckles. The lung starts to look more like liver. So if you see something that looks like liver in the chest, either the kid has a CDH or the kid has lung consolidation. You may see these air bronchograms. Oftentimes people will call it hepatization of the lung. You may see shred sign, and you may see that lung pulse that we alluded to earlier. So going back to that prior case, again, 4-year-old, history of recent liver biopsy. This is a right-sided scan, so what do we see? This is in the chest, that's diaphragm, and that's in the abdomen. So we see a hypoechoic area, both in the chest and the abdomen. So what do we have here? Yeah, blood. So we've got a rather large effusion both in the chest as well as in the abdomen, probably an unfortunate consequence of having the liver biopsy. All right. So our third case is a 13-year-old with a history of neuromuscular scoliosis who presents for posterior spinal fusion. The Post-surgical closure, the patient remains hypotensive despite repletion of what you think is the BL and what you think is adequate blood transfusion with minimal residual anesthesia on board. So very briefly, I wanted to mention the cardiac exam. I don't have time to go over it, but the focused TTE pretty much has 4 views. So you're going to be looking at the subcostal 4-chamber view, noted here, the apical 4-chamber view here, and then there are 2 parasternal views, the parasternal long and the parasternal short axis. And in all these views, you're looking for, again, gross function, a gross volume assessment, and looking for obvious pericardial effusion. So as we're looking at these, we want to qualitatively look at LV function, and there are a couple things that we look for to train your eyes to look for. One is endocardial excursion. So does the endocardium move symmetrically towards the left ventricular center? The second thing we look for is myocardial thickening. Does the myocardium increase in thickness by at least 40% as the heart squeezes? And then the third thing is the septal motion of the anterior leaflet of the mitral valve. As that mitral valve is moving, does that leaflet almost hit the septal wall? And that's in the parasternal long axis view. If you can, try to verify your findings in more than one view. So if you think you see, for example, diminished cardiac activity on the subcostal view, you could then go to a parasternal long and confirm that you're seeing what you think you're seeing. All right, so here we have a parasternal long. And just to point out the structures, this is left ventricle. This is right ventricle. This is your mitral valve. And you can see that the anterior leaflet in this normal echo is pretty much hitting the septal wall. You can see that endocardial excursion looks good. It's moving towards the center of the left ventricular cavity. You see that the myocardium is thickening in all segments. And so this is a normal echo. And for echoes, you kind of have to just take a look at several dozen echoes, and you'll train your eye to look. It's all pattern recognition, right? So you'll be able to look at this as, that's fairly normal, or you'll look at it and be like, ooh, that's bad, right? So like it's a qualitative, for the most part, it's a qualitative exam, kind of like good, a little bit bad, or like really bad. So again, to summarize, if you're looking at the normal echo, you're going to see all those things: good endocardial excursion, good myocardial thickening, and an anterior leaflet of the mitral valve that opens freely and almost hits the septum. If you're hyperdynamic, so the patient's volume down and the heart's like really trying hard to do its job, you're going to see increase in the endocardial excursion. So you're going to almost have near collapse of the LV cavity as it's contracting. The myocardium is going to be very much thickened as it's contracting more than 40%. And then that anterior leaflet of the mitral valve is going to whack the septum as it's going back and forth. The opposite is true if you have reduced function. So the endocardial excursion is going to be reduced, the myocardial thickening is going to be reduced, and that anterior leaflet of the mitral valve is going to move less robustly than in the prior picture that I showed you. So let's look at that. And I think you'll see the clear difference between these 3 images. So on screen left for you is severe LV dysfunction. You can see here again, here we go. Is the endocardium moving much in at all? Not really, right? Just kind of sitting there, looks kind of boggy. Is the mitral valve almost hitting the septal wall? No, not at all, just kind of around there flopping. And is the myocardium thickening? Yeah, not really. So this is an example of severe LV dysfunction. And even people that aren't TE certified or don't do a lot of echo, that's pretty obvious when you look at that. That ain't normal. So let's look at an example of moderate dysfunction. Okay, so a little more subtle, right? But again, endocardium, not coming in as much as that normal picture that I showed you. Is it thickening like the other picture? Not really. And is the mitral valve moving like the normal that I showed you? Well, it's moving better, right? But it's not quite getting there. So that's an example of moderate LV dysfunction. And again, just a contrast with what normal looks like. So let me give you a second to look at that. I think the severe LV dysfunction is pretty damn obvious. Moderate versus normal, you kind of have to look at a couple dozen images, and it's all pattern recognition. Okay. All right, so the other thing that we're often used to look for volume status is the IVC. We use the probe in transverse view in the subxiphoid region to large vessels, and we use our the vertebral body as our landmark. The IVC is going to be to patient right, and the aorta is going to be to patient left. So a couple different images here. So we can see normally the IVC and aorta are roughly, if you're euvolemic, roughly the same size. If the IVC, as shown in this image, is much larger than the aorta, you're either really volume up or you're backing up from the heart for some reason. If the IVC is squished and flat, looking like this as compared to the aorta, you're probably volume down. So that's kind of a qualitative assessment. Quantitatively, we can then move the probe 90 degrees to look at the IVC longitudinally, right, so along the axis. And in this image, we have to be able to visualize the IVC emptying into the right atrium. And the reason for that is we don't want to confuse the IVC with the aorta, which lies right below it. And so you have to see the IVC emptying into the right atrium. Ideally, you see the hepatic vein coming in as well, because you're going to take your measurement about 3 to 4 centimeters from the junction of the IVC and the RA, so that the IVC diameter isn't too influenced by the diaphragm movement. And so once you have this image, you can place the machine in M mode. So again, that's motion mode, which measures motion at a certain point, which is marked by this line on this machine, over time. And so this measures the diameter of the IVC as the patient breathes or is ventilated. And you can take a maximum diameter and a minimum diameter and calculate the collapsibility or the distensibility of the IVC. So normally, if you're euvolemic and you're spontaneously breathing, you should have about less than 50% collapsibility. If you're hypovolemic, that IVC is going to collapse a lot when you're breathing. Okay, so more than 50% collapsibility if you're spontaneously breathing under natural airway is indicative of hypovolemia. If you're intubated under positive pressure, the cutoff is about 20% because it's just less variability anytime patient, and you know this from looking at the A lines, there's less variability if the patient is mechanically ventilated. If you're euvolemic, it's going to be somewhere in between, and if you're hypovolemic, you're really not going to see much variation in the IVC at all. So in that third case, again, this was the neuromuscular spine who was still hypotensive despite transfusion and minimal anesthesia on board. And you can see the IVC in this image is pretty much completely collapsed, right? So while the patient is being mechanically ventilated, it completely collapses. So this would indicate that the patient is probably still hypovolemic. Again, with any echo, if you can, you want to then get a second view. This is our parasternal long. We can see that the patient is pretty hyperdynamic. The endocardial excursion is very good. It almost completely collapses. You can see the patient's a little bit tachycardiac. The thickening is good. The mitral valve is moving freely, whacking the septal wall. All this indicates a patient that has good cardiac function, but is just volume down. So then you treat it accordingly. All right, so in our fourth case, we have a patient that's 14, autistic, presents for a dental procedure. The pre-op nurse says that the patient told her he had some crackers this morning, but the parents deny that he ate anything, right? So how many times does this happen in your practice? Never. Just kidding. So we're going to talk a little bit about gastric ultrasound, and in order to do that, we have to review gastric anatomy. So I have children, so I know this to be true. The space in the stomach for real meals is about this big, okay? But there's plenty of room for dessert and snacks. For anybody that takes call in pediatrics, we know that there's a spot in the stomach for pennies, Legos, and like button batteries. Okay, so in all seriousness, let's look at the gastric anatomy. So as we're scanning in the sagittal plane, meaning you're holding the probe vertically so that it's pointing from head to toe. You're going to use your liver as a landmark, and the most accurate way to scan is with the patient right side down. And the reason I say that is because when you're right side down, your antrum by gravity is going to come down, and all the food and contents by gravity is going to come down. So that's going to give you your most accurate measurement. So in an empty stomach, again, you use your liver as a landmark. Your liver is huge, you can't miss it. And then I look slightly to the patient's left for the antrum of the stomach. In an empty stomach, you're just going to see the muscular wall of the stomach and the inside of the stomach is going to be extremely small. So just a tiny bit of clear fluids in there, which is normal gastric juices, okay? Some people call that the bullseye appearance, and there's really going to be, whether the patient's lying supine or right lateral decubitus, there's going to be minimal content in that stomach. If a patient has just drained clear liquids, this is what the stomach looks like. So hypoechoic content inside. The stomach is now stretched, the wall appears thinner, and there's this dark or hypoechoic content inside. In this situation, you're going to have a bigger stomach when the patient's lying right side down because the contents are going to pool by gravity as compared to if the patient was supine. In the early solid phase, meaning the patient's had some solids, some liquids, and inevitably when you eat, you swallow air, you get this frosted glass appearance. And the reason for that is that when you swallow air, the air is in the stomach, air is like the death to ultrasound, right? So you don't see anything posterior to where the air is, and so it's just dark after that, and you get this frosted glass appearance. This means that the patient's recently eaten solids, liquids, air. You can't really do an accurate measurement, but they've recently eaten. In the late solid phase, so roughly, an hour and a half, 2, 3, 4 hours, depending on how quickly the patient's moving contents through their stomach, you get this late solid phase where the liquids, the air have moved on, and you just see hyperechoic or bright stuff inside the stomach, okay? So in this situation with this kid, I did a quick bedside ultrasound. I pulled the machine to the pre-op area and I did a scan, and we see here that the kid clearly has solid contents inside the stomach. And I pointed, when I do this, I explain it to the patient, I explain it to the patient, to the patient's family. I say, hey, this is liver, this is the stomach. I see solid contents in there. I never accuse them of violating NPO. I don't know how it got there, but your patient, your son, your daughter still has solid contents, and then I explain the risk of aspiration. And so when I postpone the case in this situation, the parents are less mad at me because they've visually seen what I'm looking at and what I'm concerned about. All right, so finally, the last 2 minutes. A lot goes into developing an ultrasound program. First thing you got to do is have education, right? So you have to teach providers how to do it. At our institution, we incorporate into our fellows boot camp. We do an intensive weekend course. Our next one is coming up actually November 4th. And then we do sort of mid-year reviews as well. There's certainly external sources as well. I know the ASA does a course, ASRA does courses as well, the SBA does courses, there are online resources that you can look at. So first of all, people have to get their sort of baseline education. And then you have to assess whether or not they're competent, and hopefully people feel comfortable. So multiple studies have been done showing that roughly 25 scans, whether it's lung or cardiac, is a good number so that point-of-care providers have images and diagnoses that meet the gold standard. So for an echo, the gold standard is usually the cardiologist, right? For some of the other things, it's the radiologist. If you've done 25 scans, for the vast majority of people, they are competent. And so at our institution, we've opted to incorporate that into our credentialing process. So providers have to do 25 cardiac scans, 25 thoracic scans. Images are saved because of our workflow. I'm not always in the room with them, but they save them, and then I review the images after the matter. They have to tell me what they think they saw, if there was any abnormalities, and then I do a check of that. And then once people have completed that process, they're credentialed. Different institutions may opt to do things different way. I know the ASA has a certification program now, which is kind of like this, but not every institution may have somebody that can overview and oversight this, so they have external reviewers. But I do think that review process is very important, not only in making sure that the provider is not going to misinterpret the ultrasound, but also so that the provider is comfortable and feels confident in pulling out the ultrasound machine and using it in time of crises. And then from an administrative standpoint, you can bill for this. Our department does bill for this. I don't know how much money they get from it, but in order to bill, you have to have an image saved, and there must be an interpretation in the medical record. Okay, so those are the two things. Many studies have looked at barriers of implementing an ultrasound program. The most commonly cited things are lack of machines. Okay, so if you don't have an echo probe, you can't do an echo. Time pressure in the OR. We're all very busy, and so this is an extra thing to do. And then ultimately provider comfort with the ultrasound. Alrighty, I guess it's question period for everybody.
Thank you very much, Dr. Lin. We're now going to begin the question and answer portion of this session. If you do have a question, we're gonna get some portable microphones up here, and feel free to come up and ask your questions, and we'll get some answers. All right. Well, I'll start it off. This is for Dr. Hamlin. In regard to testing, would you ever say you have a patient in pre-op and they say, I heard my grandpa had high temperatures with anesthesia. Is there ever a situation where you would delay a case and have a patient get tested for MH susceptibility?
Good question. I think this situation comes up very frequently. My bias is I know that I can provide a safe, non-triggering anesthetic to most people. So unless there's a contraindication to providing a total intravenous anesthetic, I wouldn't necessarily delay a case. That being said, if there's any indication of even a potential family history of malignant hyperthermia, I always err on the side of safety and do non-triggering anesthetics. The common question I always get from colleagues is like, well, it's a fourth cousin, can I do SIVO? And I think that the safest thing is to do a non-triggering anesthetic in that situation.
Question for Dr. Galler. On chronic pain patients, we have a lot of trouble with the medical board in Texas with patients who we have on an opioid, even microdosing in the pumps, who are also on benzodiazepines for psychogenic problems, psychotropic problems, plus the psychotropic drugs. How do you deal with we have a very large pump population, and we're constantly getting audited because the PMP indicates that they're getting a hydromorphone in microdosing, but at the same time they're on benzodiazepines, and if we take them off, then they go crazy. But how do you handle that?
In our adult facility, University of Nebraska Medical Center, they established a rule where if they're getting opioids, they absolutely will not allow them to have benzodiazepines at the same time, even in a treatment where, probably in my estimation from our own experience in kids, I think it would be warranted. I think diazepam is a really good muscle relaxant for certain types of surgeries like posterior spinal fusion, pectus excavatum repair, those types of things. And we do send them home, the primary providers, with a small regimen of diazepam and opioids with Tylenol and ibuprofen. But in the adult hospital, they just eliminated it altogether, to the point where they take care of kids, even with recommendations, they will not give it. For muscle relaxation, if we're faced with this conundrum, we do use methocarbamol or Robaxin. It isn't a benzodiazepine, but it is a CNS depressant and a muscle relaxant. But I can see the conundrum, especially with the microdosing. I know that benzodiazepines typically are not prescribed as a long-term regimen for people, but more of a PRN, and then have another like psychotropic as you were describing. So I think this continues to be a difficult situation, especially for those that came from before. All of the focus on the opioid epidemic highlighted some of these challenges that have occurred when people taking both of them together did ultimately lead to overdose and death, being that they're both depressants. So that's why they're probably auditing those that have been stable on it for probably 10, 15 years before all of this became an important discussion.
Very unfortunate. We have probably 200 patients that are on under 150 micrograms per 24 hours. Doesn't even show up in their urine. Yet, if they're on even 0.5 clonazepam at night to help them get to sleep, it still shows up. So, I mean, it's crazy that they've gotten just they've gotten really overdone on this opioid and benzo thing.
Well, the truth is there are unintended consequences when there is a focus on restrictions, and one of the things we've seen in kids is, I think California at one point, they were talking about allowing pharmacists not to fill prescriptions for kids 6 and under if they didn't feel that there would ever be an indication they could need an opioid. And we take care of a large osteogenesis imperfecta population who, by 6 years of age, some severe kids have had hundreds of fractures. And so having a blanket rule and not having it be customized per the patients, I think isn't the way that we should go. But I think having some attention to it so that those that shouldn't have that layering are getting the right attention and the focus to shift to something else is part of the longitudinal need. So it's difficult.
Just one question for Dr. Lin. Is there any application for ultrasound in pediatric trauma to detect rhabdomyolysis or other muscle damage?
I haven't seen that specifically for rhabdo. Is that what you're saying? Not really. I haven't seen that. I mean, certainly in pediatric trauma, the surgeons are using fast exam in the ED to look for free fluid, although the gold standard is still CT in that situation. But no, I haven't seen them, or we don't use that for that.
I have a question for Dr. Lin regarding the new handheld portable ultrasound devices, image quality, and overall functionality compared to, they're obviously not going to be good as the stand-mounted and console devices, but for some who might be contemplating purchasing a handheld device.
So that's a great question. The image quality has improved dramatically over the last 5 years. If you look at like the initial Butterfly versus the Butterfly that's out now, the image quality is much better. I'm not here to talk about different brands, but Philips puts out a nice, if you're doing cardiac, Philips puts out a very nice cardiac probe that can connect to your iPad. I think you hit the nail on the head. It's never going to be as good as a device that's as big as a laptop for multiple reasons. You're doing an all-in-one probe in something that's the size of my palm, right? So you can't expect that to be as good as having 4 separate probes. A curvilinear, a large linear, a small linear, and a true echo phased array. But knowing those limitations, I have done 22 gauge IVs with a handheld ultrasound, no problem. I haven't personally tried a 24, but certainly any adult size IV would be totally fine. I think you get 18, 20, whatever. The echo quality is actually pretty good, so I feel comfortable using that if I don't have a regular machine, so to speak. Lung is fine, certainly bladder, abdomen. So I would try out a couple different brands and just kind of see what you like best. They all have their pros and cons.
I had a question for Dr. Lin. I don't suspect a lot of your patients are on Ozempic for weight loss, but as you know, the ASA just came out and said if they haven't discontinued in the time frame they're recommending, to treat them as full stomach unless you do gastric ultrasound. And we had a great talk last year by George Williams, but I remember leaving that talk just sort of trying to figure out the practical application of that and how to use it in my practice. I wondered if you could give us any hard numbers or exactly what we should be doing, because the ASA kind of just left it there.
That's a great question. We're actually doing a study on kids, pediatric patients, on the GLP-1 RAs at our institution. So hopefully when that data comes out, anecdotally, yes, children on those drugs do have a full stomach as compared to, not surprisingly, right, because adult data shows that. We don't have pediatric guidelines on that yet. I personally, so this is not a society recommendation, but I personally scan those kids because we don't, at our institution, we haven't implemented be off drug for 3 days or a week, and NPO for solids more than 24 hours, and clears 24 hours and no more than 6 hours afterward. So we as an institution have not done that, but personally, I do scan the stomach. I think even with guidelines like that, there's going to be variability, right? So you could have a patient that's appropriately NPO by your guidelines, so no solids for more than 24 hours, no clears for more than 6 hours, and they could still have a full stomach. And again, anecdotally in non-published data, we still have seen that. And so I think the best thing is if you can see it, kind of like that that anesthesiology editorial, like if you can see it, that's better than any blanket guideline, right? So you do a quick gastric ultrasound. For those that were at the workshop yesterday, it doesn't take long. It's very easy to do. You can clearly see if there's solids. You can clearly see if there's liquids. And then you, as the attending anesthesiologist, need to make a decision based on what you're going to do. I think part of the problem is our guidelines haven't evolved to that point. I think we're still waiting for some studies. So legally, are you protected, right? So if you do a gastric ultrasound and you're like, the kid's empty or the adult's empty, and you proceed and the patient still aspirates, legally, are you protected? They can still come back and say, well, your ASA guideline said this child should have been NPO for solids for more than 24 hours and, clears for at least 6. And where does that leave you? So I'm sorry, I don't have a better answer for that. I can tell you what I do, but I'm not sure that our society guidelines have caught up yet.
I'll add that we do have a keynote during this conference by Dr. Anu Wadwa that's specifically on GLP-1 inhibitors and obese patients, and so we're going to get more enrichment from that too.
All right, I have a quick additional question for Dr. Geller. You did touch base on over-the-counter naloxone. I was wondering in terms of what patients you think might benefit from this, prescribing practices for certain patients, and should we be recommending or prescribing over-the-counter naloxone more frequently in patients that are going home with opioids?
That's an excellent question. I think there's a lot of discourse as well as research being done on this topic because having accessibility of a cheap and easy to use remedy for anybody, everybody knows how to use a nose spray even if you spray it in the wrong direction, is important. I don't know that we educate on this being part of what people can have or prescribe it as frequently as we should. But I think those patients that we have that we know are going home with greater than 20 tablets or so for a more significant operation, it wouldn't be unreasonable. But there's also the opposite side, the con, where what if they were nervous at a moment when they were taking a nap and then they sprayed it and then completely reversed it for a moment. But I think that's less of a negative side than to have it in case. They're dehydrated, they're still taking it around the clock, and for these types of families that are potentially not interpreting their instructions right. I think the adult population probably needs more of a movement to having those available, especially after traumas and orthopedic surgeries where they're having prolonged care. What do you think as somebody who takes care of pain all the time?
Yeah, I think implementing education is the biggest thing, especially in our pediatric population, where it's implementing or educating parents on when and when not to use it, and then making it widely available to the various populations that we reach. The price I have heard is actually close to around $80-ish. So that's obvious. I think that's hard for a lot of patients to justify, especially the different demographic of patients that we see. So how can we provide that opportunity for patients at a lesser cost, and giving it to the community, I think, is difficult for sure.
Agree.
I have an additional question for Dr. Hamlin. Actually, 2 questions. Timing of a MH reaction in terms of acutely and the potential for a delayed reaction. Can you discuss that briefly?
Yeah. Okay. So I think with the agents that we use today, particularly sevoflurane and desflurane, they're less of an anesthetic or trigger for MH than, say, our historical agents like halothane and isoflurane. There was an animal swine model that exposed the pigs to halothane, isoflurane, sevoflurane, and desflurane. Halothane triggered very quickly, within 30 minutes. The isoflurane was a little bit longer, and then even up to desflurane was up to, I think, around 180 to 200 minutes of exposure before for seeing signs and symptoms of MH. I think that also goes into the discrepancy between the genetics that we see. So, big population studies, RYR1 mutations occur in about 1 in 1,500. However, we're only seeing reactions in 1 in 5,000 to 1 in 100,000, depending on which study that you're looking at. So, I think with the newer agents, we're not seeing the kind of getting into that fulminant crisis as much as say in the earlier days. Second question was again? Delayed reaction, yes. Yeah. I think delayed reactions need to be investigated very, very closely. One of Dr. Lin's colleagues, Dr. Littman, put a paper out, I believe in, I want to say 2014, looking at suspected MH crises in the PACU. And with further investigation, all of those suspected cases of MH were attributed to other things. So I think if you have concern in the operating room, you need to investigate it very closely. If you have concerns in the PACU, definitely investigate, but I think most likely it's going to be leading you down another path.
What's the longest time between exposure and somebody actually showing verified MH? Because there's that question, is it 6 hours? Could it happen within 24?
Yeah, so I think if you're continuing to expose them to a triggering agent, I don't think there's a time cutoff. But as far as, if you are no longer providing that triggering anesthetic, then I think you need to be looking at other causes.
And the process for contacting M-House, it's just a number, it's 24/7?
Yep, so there's anywhere from 3 to 4 consultants on call at a time. It's a 1-800 number. I don't have it memorized. I'm sorry, I probably should. And yeah, 24/7, 365, we're always happy to help. If you have an MH crisis, you feel like you've got it under control, I would still call. I think we can provide benefit even if you've got the situation completely controlled. There's just a lot of resources that we can get you plugged into for both you as a provider. The other thing that I find, and I always do in my practice as a consultant, is I'll provide my personal cell phone number to the provider to hand off to the next team that's going to be taking care of it. Because we as anesthesiologists, this is something that we're familiar with, even if we've never seen it. However, you might have an ICU intensivist that has never seen this before and may have questions. So
That's a free service?
it's free. Yep, free.
The PD Crisis app is a free app that you can download on your phone that has different various pediatric emergencies, MH being one of them, where if you are concerned, you can pull it up and go down the checklist, go down the treatment. It's an amazing resource. I do recommend that.
The M-House organization also has an app as well. So if you're taking care of non-pediatric patients, it's available as well.
Regarding the opioid epidemic, and Dr. Geller touched a little bit on this about the EMR and chart advisories, it's a huge benefit to implement that. When we started implementing that, where if you're prescribing over a certain amount of opioids on discharge, if you're over our hospital limit, an advisory pops up and says you think you're over this 5-day or 3-day or 7-day limit. Is there a reason or necessary? It helps residents, it helps fellows, because a lot of times they don't know. They see dispense amount and they put 1,000 milliliters and they just send a 4-year-old home with a liter of oxycodone or something. And if you have that chart advisory, then it causes a light bulb to them to say, oh, why did I do this? I need to contact someone because I'm not really sure. Otherwise, it just goes to the wayside. No one knows. They go to the pharmacy. So if you can implement that, I highly recommend it. Talking to your IT, talking to your surgeons, it's a huge benefit for the population, and we've seen wonders since we implemented that. I have one last question for Dr. Lin. So as you discussed, some of the limitations to using ultrasound in the hospital is numerous things. I don't have time. I'm running 2 rooms. We don't have enough ultrasounds. There's 24 of us anesthesiologists. We have 4 ultrasounds. How do you overcome those limitations?
Yeah, unfortunately, it comes down to like everything, right? Time and money. So, um, to a certain degree, the department has to be willing to invest, right? So, 4 ultrasound machines for 20 ORs, you're going to be limited in how many you can do. And it took me being at CHOP 12 years to get 1 machine in every OR. But again, we have the resources to do that. So, I know
Does the billing pay for it?
not in total. So,
But it offsets
it
enough for
offsets-
administration to say, oh,
yeah.
oh, okay.
But to a certain degree, the administration realized that that was important for patient safety and patient care, and they were willing to fund that. In terms of, I have 2 rooms and I'm busy, I don't know how to do ultrasound. The other thing that we've built is sort of like a POCUS team. So we subspecialize probably more than we should at CHOP. So we have, for example, a difficult airway team. So a group of people that are interested and are really good at doing extremely difficult airways. And as anesthesiologists, even having been there over a decade, if it's a really difficult one, I call on them. Same thing with our POCUS team. We have several individuals that are very facile, interested, love doing it. And so I often get called into an OR, hey, can you just come do a quick POCUS? I'm not sure exactly what's going on with this patient. Like, they're hypoxic. Like, the surgeon was just doing a line, they drop a lung, can you come look real quick? And it's not a problem. If I'm in the OR that day, I just pop in, do a quick exam, in and out. The attending doesn't necessarily even have to be there. If he's busy, emerging in another room, I can pop in and while the resident's there and do that with the resident. So I think team-based approach. But in terms of the hardware, like, the institution just kind of has to be able to invest in some degree. It doesn't have to be 1 ultrasound for every room. I think if people want to do the handhelds, those are significantly less expensive. Like, the butterfly is like $2,000, so it's not a huge amount of money. The only problem is keeping track of it, right? So if everybody is responsible for their own butterfly, that's one thing. But if you're like, I have 5 for the department, I'm not sure how you guys work it, but I know ours would disappear in about a week. So, but that is an alternative if the handhelds are way less expensive than the laptop on a rolling cart devices.
I'll put a quick plug in. We do a POCUS workshop at Children's Nebraska yearly in October. So if you're interested, just Google it or reach out.
It's actually this coming weekend.
Yes, in collaboration with physicians at CHOP. Thank you, everyone, for coming. We're now going to have a break until 9:30 when we start the next session. Please join me in thanking Dr. Ryan Hamlin, Jess Geller, and Elena Lynn for taking the time to provide us their expertise. If you could provide your feedback, completing the brief evaluation on the mobile app, select this session, and then answer the quick survey questions. We'd greatly appreciate it. And feel free to visit the exhibitors, thank them for their time, and what a great, now we're at the middle of the conference, so we appreciate everyone coming and taking the time and setting this up.